The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. I am Tony Urbanic, and this is the next episode of TMD Demystified. Today, we're going to talk about TMD and OSA, temporomandibular joint disorder and obstructive sleep apnea. It'll be titled TMD and OSA. Very interesting topic, tying these two diseases together, and I have a lot to say about it. But before I do that, I'm going to diverge a little bit again regarding something that happened to me in the clinic here yesterday that I just want to bring to your attention. Beat the drum, if I may, regarding the terrible amount, significant, extreme amount of misdiagnosis, mistreatment, misdirected of actual TMD patients out there in the medical community. I'm not beating up on the doctors. I am one, okay? But it is true. It is fact. They just don't know it. They don't know how much they don't know about TMD that they should know. So let me just briefly describe what happened yesterday with a patient that I did a consult for. Patient was a 14-year-old female brought in by mom. It just so happened that mom was a licensed practical nurse that worked in a convenient care clinic in a small city just to the south here of Nashville, Tennessee, probably about a 30-minute drive. And as the consultation went out and the story rolled on and I collected symptoms, and the symptoms were obvious, this young child, 14 years old, had most of the symptoms. As I recall, the big problem was earaches. The most significant symptom that this child had was constant and severe, beginning with recurrent headaches and then, recurrent earaches, and almost continuous earaches, but her symptoms also included headaches, jaw pain, neck pain, and kind of unusual for a 14-year-old, had a certain amount of subjective hearing loss and vertigo associated with her symptoms, but definitely had TMD symptoms. And so what I found out rather rapidly was that even though mom worked in a clinic, a convenient care clinic, with these symptoms from her daughter, she had ended up, after seeing her PCP, was sent to two separate ENT doctors, who both of them examined the patient, 14-year-old, and said, there is no ear infection here. And then the next thing was, well, what do you do about it? And both of them said, I don't know, but it's not ear infection. So as it turned out, she actually went back to where she worked and asked the nurse practitioner who works in that clinic to take a look at her daughter. And fortunately, this particular nurse practitioner was very familiar with our practice and our clinic and the Urbanic device and protocol, did an examination and pushed on the temporomandibular joints, which were hot, inflamed, and elicited tremendous amounts of pain. And she told mom, this is not ear infection, this is TMD. And again, when I finished the examination, pushing on the joints was obvious. I mean, it brought tears to this little girl's eyes. The point being, this is pandemic. This, what I just described for you, is pandemic, and is one of the main reasons, if not the main reason, that I do these episodes and do this podcast, is to send out information and messages and education. But it has to start from the dental community, because the medical community is just disjointed from the problem itself. They don't know anything about it. They don't know anything about it. They don't know that they should know about it. Now, there are exclusions to that because of the way we market here in Middle Tennessee. And I have many, many other ENT doctors who send us patients constantly. And once they get the gist of it and they wise up and know how to recognize it, which is so easy, symptoms plus hot joints mean TMD. So, it's works very well for us, but throughout the United States and probably the rest of the world, this problem ends up like the experience I had yesterday with this mother, who, by the way, was more than apologetic. She literally broke down into tears when I confirmed the diagnosis, and she felt so bad because her daughter had gone on for a better part of a year and a half with these excruciating symptoms, and she felt so bad because she didn't figure it out beforehand. Well, a licensed practical nurse is not going to be able to figure this out by herself. And when she relied on the medical resources, they let her down big time. All right, enough said on that, but this is just one of thousands of stories that I hear and heard, and I heard one yesterday, and I thought that I'd share it with you and understand why we're doing this, why I'm doing this podcast, and why I do these episodes. All right, so let's get back to TMD and OSA. The reason I bring this up, and I've touched on this a little bit before, but we're going to take a much deeper, as they say, deeper dive into the issue itself. Now, what's the issue with TMD and OSA? Well, first of all, TMD is a discrete disease. OSA is a discrete disease. The problem is that what I see is the dental profession overall, or certain dental professionals, and even some educational outlets, dental schools, are trying to make a connection between these two diseases as one causing the other. OSA causing TMD, TMD causing OSA. And they even quote literature about this, which I'm going to bring up, which is just kind of not true, but where I'm going to prove the point. TMD is a separate disorder, which I've talked on obsessively in these episodes, and described how inflammation within the temporomandibular joint creates all the symptoms directly. And if you get rid of the inflammation, then the symptoms go away. And we can prove it. We've got the data, we've got the study. But there's an increasing number of practitioners out there, mainly practitioners, who get their information elsewhere, who want to show that the two are connected, and that is the substance and the reason why they develop these practices that they call themselves blah-de-blah clinic or so-and-so doctor for the practice of TMD and OSA, and that they're not one and the same, but they're connected, and you can't practice solving one without the other. So let's explain this a little deeper. As an example, and it's the reason I chose this topic. is I was doing some due diligence on the internet, and I ran across a practice that fit that description that I said, and the description was the practice was limiting itself to TMD and OSA. And I got on the site, and this practitioner went on to describe how people with OSA, obstructive sleep apnea, because they have problems sleeping, that it is related to the creation of TMD. In this particular case, he noted in his description of his practice and how things work that patients, when they have obstructive apnea, they automatically, while they're sleeping, push their jaw forward to open up the airway. And he states that in his practice description of what it's all about. And that is involuntary while the patient is sleeping, and when they go apneic, they go like this and protrude to open up the airway. Well, there is no science behind that. That is a bogus statement. There is no science behind that. It is not based on any kind of known experiments or anything else. It's just pulled out of midair. And it's one example of this kind of thing that's going on within our profession. And in his website, to fully validate what he says, he uses a reference that I looked up. I pulled up the reference, and I'm just going to give you the title. Here's the reference right here. And I read the reference, and it's entitled Sleep Apnea Symptoms and Risk of Temporomandibular Joint Disorder, the OPERA cohort. And the OPERA cohort is a large study done on temporomandibular joint problems, describing a more than 2,000 group of people who were followed along over a period of time, and how many of them developed TMD. So the OPERA cohort and the OPERA study is well documented and often quoted in many different ways, as it's quoted in this study. But on reading the study, first of all, this particular practice and this doctor who says that while you're sleeping and you have an obstructive event, you move your jaw forward automatically, uses this study to validate what he just said, what he says. He used this study to validate what he quoted in writing on his website. And I can tell you, after reading this study, it doesn't say anything about that. It doesn't make any reference to moving your mandible forward during an obstructive event. So that's a really good example of either he didn't read the study, or just picked up a study that sounded good and used it as a reference. What this study does do, what this study is a study of, it is a very pedantic statistical study of sleep apnea, making the relationship between sleep apnea and OSA only through statistical analysis of the OPERA cohort, of this prior OPERA study. And it's the most convoluted study statistically that I've ever read. Now, I'm not a statistician, but I did take a couple statistics courses in my career, particularly one in my master's program. And I can tell the difference between a usual coherent statistical study and something that is so convoluted and out to the extreme of statistics I need to quote a quote that has been attributed first to Mark Twain, but actually he attributed it to Benjamin Disraeli. And the quote is, "Lies, damn lies, and statistics." And I think this is really a good example. This study right here, where does it come from? It comes from JDR Clinical Research Supplement, July of 2013. And by the way, it's 10 years old. So this doctor quotes a 10-year-old study, a 10-year-old document. It's a convoluted statistical analysis of a prior study and uses the most extreme technical methods. In fact, they're so extreme, I've never heard of them, rather than the usual statistical analysis. And it really boils down to what Mark Twain quoted and attributed to Benjamin Disraeli. By the way, if you didn't know, you don't know your British history, Benjamin Disraeli was a prime minister in Great Britain twice, roughly in the middle of the 18th century. Extremely talented, well-known politician, author, and highly thought of in the British Empire. And his quote, I think, needs to be recognized when you deal with scientific analysis, because there's nothing wrong with statistics. They are important. In fact, they are critical to our understanding and use of critical analysis of scientific data. In fact, it isn't used as much as it should be, but not in a convoluted, extreme nature, trying to prove a point by unusual kind of statistic analysis. So according to Mark Twain and according to Benjamin Disraeli, there are lies, there are damn lies, and there are statistics. All right, made that point. So what's going on here? For those of you in dentistry who are not familiar with obstructive sleep apnea, let me try to explain with a little hand description. We thought back when I started oral and maxillofacial surgery, my ENT colleagues, where obstructive sleep apnea and treatment of first started out through ENT, they core out the pharynx, called a UPPP, uveal palatoplasty, where the tonsils were removed, the uvula was removed, part of the soft palate was basically coring out the soft palate and upper structures of the posterior pharynx. Well, that was an extreme surgery, and I had exposure to several patients. I did not do that surgery. ENT surgeons did that surgery, but I was exposed to several of my patients who came in, ended up in my practice, who had that surgery and continued to have obstructive sleep apnea. And of course, maxillofacial surgeons have worked out, beginning with our use of orthognathic surgery and doing a maxillary and mandibular advancement, basically Le Fort 1, osteotomy, mandibular osteotomy, bringing the entire lower face forward in extreme cases of obstructive sleep apnea. And that operation is a big operation, basically a two-jaw operation, which is not extreme, but it works really well for obstructive sleep apnea when nothing else works. And that's how I ended up with a couple patients who had UPPP, and they were in my office basically requesting maxillary mandibular advancement. But the UPPP, if the upper and lower osteotomies, if you think those are significant surgeries, which they are, the UPPP is an extreme surgery. The patients would complain of extreme pain for a minimum of 2 weeks after that was done. You can imagine difficulty in swallowing, eating, plus the pain involved. All right, a little history, a little background. What we found out, though, is ENTs finally figured out that that was not a successful surgical procedure, and the actual obstruction is in the base of the tongue, the back of the tongue, as it is in association with the posterior pharynx. So again, for those who have no indoctrination on obstructive sleep apnea, the posterior pharynx is a tube, which is the upper part leading to the trachea, vocal cords and trachea, larynx, vocal cords, trachea, which is not a round tube, it's a flat tube. And in a patient who does not have obstructive sleep apnea, behind the tongue being out here, the base of the tongue, which is this wall of the airway, in patients, normal patients, there's a certain amount of airway that is there, and when the patient goes to sleep, the muscles relax and the airway narrows, but there's still enough room to get air up and down while they sleep. In a patient with obstructive sleep apnea, due to age, increasing age, increases the flaccidness of the muscles and the tissues of the neck, like me. And if you gain weight and the neck increases, and the neck size always increases as we get older, but it decreases the airway size. And now when the patient goes to sleep, the muscles relax and the airway collapses. And until the patient wakes up enough, they're not going to move air up and down that upper airway behind the tongue. And that is the description of sleep apnea. And there are different methods that have been used to treat that. The standard of care, I believe it still is the standard of care, is the CPAP machine and mask, which under positive pressure blows intermittent breaths through that obstruction. You have to wear a mask, and you have a machine, and it actually blows room air down through the obstruction into the lungs. Patients hate it. I've talked to very few patients who like it. The effect is good, but as far as they having interest in wearing a mask with a machine all night long, every night, most people hate it. And so in our profession, using oral devices to bring the mandible forward has become an art and a science, and is very effective in a great number of patients. Not all the patients, but in a great number of patients. So that is the state of the art with obstructive sleep apnea. But there's nothing about obstructive sleep apnea that actually creates inflammation within the temporomandibular joint. And it is totally inappropriate and unscientific and based on nothing to say that when the patient is sleeping that they move their lower jaw forward. What happens, though, if a patient is placed in an oral device, and until we totally focused on and limited our practice to TMD as an oral maxillofacial surgeon, doing a good number of maxillomandibular advancements when appropriate, but I also treated a lot of patients non-surgically with sleep devices, based generally called sleep devices, and they all work the same way. With traction, they bring the mandible forward. Usually the gold number is 7 millimeters. You start out with about 7 millimeters, and that usually takes care of most people. If you go out to 9 millimeters, it gets really uncomfortable. Usually less than 7 millimeters, you don't get quite the response. So as in my experience, if you bring that mandible forward, in the average, mostly men, some females, but mostly men who have obstructive sleep apnea, that will usually get them out of trouble with their wives who constantly complain of the snoring, but more importantly, give them a better quality of life because they're not tired all the time and falling asleep over their meals and having the danger of falling asleep while driving a car, which happens. And I've talked to people who gave me that history. But the point is that when a patient is brought forward with a sleep device, it disoccludes, if you will call occlusion, but it brings forward the condyle out of the glenoid fossa. And that is why I have seen, after treating multiple patients with both sleep apnea and TMD, that patients in a device itself will create TMD. That is why orthodontic appliances that pull the mandible forward will create temporomandibular joint inflammation and damage, and eventually the symptoms of TMD when the inflammation within the joint gets so extreme. So it is true that using a oral device for the treatment of obstructive sleep apnea will create TMD. There is nothing about OSA itself, that is untreated OSA, that creates TMD. Doesn't happen. And that part of this study, which I quoted again, in this study, they use these, again, convoluted statistical analysis, extra statistical analysis on statistical analysis, and they don't even address the fact in their own analysis that a lot of the patients they relate to in their statistical analysis a certain number of them, whether or not they have been placed in an oral device or not placed in an oral device. They just say statistically patients with the diagnosis of obstructive sleep apnea, whether or not they've been treated was not even addressed on here, which is significant, overlooking the problem itself. So to get through this again, anything, orthodontic appliance, Herbst appliance, and sleep appliance that pulls the condyle out of the glenoid fossa for any length of time will create damage within the temporomandibular joint. It isn't operating correctly, which eventually will create chronic inflammation, which eventually will cause headache, earache, jaw pain, neck pain, ringing, fullness, dizziness, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of locking. That's just how it works. So, I guess let's call it a warning, but a wake-up call. I'm not out to beat up anybody. I'm out to wake people up, to get them focused on the things that are actually happening and not made up in their minds about either TMD or OSA. So I am familiar with OSA. I treated it. I have many, many, many patients treated both surgically and non-surgically. I preferred non-surgical, but for the extreme cases, we did maxillary mandibular advancement. It's a good operation when needed. But trying to make a practice or bring in some kind of description how one causes the other is not appropriate. It's not based in science. It's not based in science. So if you want to have a practice that's totally limited to TMD, or a practice totally limited to OSA, or even a practice totally limited to OSA and TMD, is, I think, a great thing. I think more dentists need to step up and take on the responsibility of treating these two diseases, but trying to connect the two diseases to justify your practice or why you're connecting them together is inappropriate. Inappropriate, wrong. So getting back to lies, damn lies, and statistics. I was taught my oral maxillofacial training by my mentor, Dr. David Hall, who's an icon in oral maxillofacial history, all about critical thinking. And to actually, just because it's written, just because there's an article on it, even just because there's statistical analysis associated with it, does not make it correct. If it doesn't provide reproducible information that can be understood in a logical way, which is critical thinking. Critical thinking. I've made my point, and I hope that it's a little technical. There's a lot of people that go, well, that's pretty much, I'm really interested in just treating the patient and getting on with it. I don't have to uncover all of the specifics of why things shouldn't be. Well, the more understanding, the better. The more understanding you have of all the aspects of TMD and trying to combine OSA to TMD is one of the aspects that we need to clear up, which is the purpose of this particular episode. So for those of you who'd like to learn more about the simplicity of treating TMD, it's quite simple. I've already explained it. If you can make the inflammation go away by putting the patient into a device that unloads the temporomandibular joint adequately, unloads the joint adequately by separating the back teeth with a protocol. Protocol is very important. You unload the joint long enough, the inflammation will go away. The inflammation goes away, the symptoms go away. They use the device according to protocol, which is indefinitely for the rest of their life. Then they can keep comfortable, symptoms don't recur, and patients will be happy campers. If you'd like to learn how to do that, or learn or just have more information, you can see our website at www.urbanictmj.com. If you'd like to talk with me, if you'd like to communicate with me, if you'd like to criticize me, I can be reached at Tony at tmjservices.net. Our Director of Education and Marketing, Dr. Naomi Williams, who it really leads the charge here about getting other doctors in line and on service in the network with TMJ Services. She can be reached at Naomi at tmjservices.net. Until next time, I look forward to speaking with you on the following Tuesday. I hope you have a successful week, and I certainly hope you have every success in treating TMD, and if you so choose, treating OSA. But they're not the same disease, and they do not have a direct relationship. I'm Tony Urbanic, and this is TMD Demystified.